Hey everyone, welcome to First Aid AMC Clinical. Can you guys hear me properly? Brilliant. Okay, so if you can't hear me or if there is any lack of sound, if you find there is connection error, just let me know. Please write it in the chat box. Now, this class is recorded, and because this is a role play session, we prefer that you guys do it as an interactive session with us. And also, if you feel free to open your videos, please do so that we can become interactive and we can get to know each other. And when you're doing role play with us, we can see your like how you are interacting with the patients. What is your body language? What's your posture looks like? How you change your way of talking when a patient is unwell or showing some kind of when you need to show some empathy or kindness to the patient. So feel free to open your videos and we can start our tonight's session. So let me introduce myself. I am Dr. Rakib. I am one of the founder and one of the mentor of First Aid AMC. I'm not too much attached with the online classes, but you might know that I take the physical examination workshop in different states in Australia. Like we had one session in Melbourne earlier this year, which was the April workshop. There is gonna be another workshop in Sydney. I believe that is in September. So I do those kind of sessions, but given there is a unexpected issue happened with Arshan, so I thought like we need to take over. We need to give you some kind of support during this time. So that's why I'm here. So as a small introduction, I am a working doctor in Australia. I've been working for a long time in here. I have worked in hospital settings. I worked in GP settings, and basically I'm a general practitioner with skin cancer specialty. Okay. Now, as you might know from the various posts that we are doing in Facebook, the course structure has changed a little bit for our first aid AMC clinical, and it is only for this year. Next year from January, it will go back to normal. But I'm very excited about this year change, and I want to also know how this can be helpful for the AMC candidates, and I want to see that if this is something that we can continue. Okay, so for this AMC Clinical Rapid Recall and Roleplay course, the course is not designed for beginners. I know you are in different stages of your preparation. I know that many of you might have just passed your MCQ. I know that you might be in the middle of your preparation. Maybe you have already got your exam date and you just want to finish the recalls as soon as possible, and very rapidly you want to get to know the cages, right? So my strong recommendation is that this is not a course for a beginner who just passed MCQ, because we're going to be fast. We're going to do role plays, fast feedback, and finish cages as much as we can. For a beginner, this is going to be very, very overwhelming. So if you are a beginner by any chance, and let's say that many of you I can see are not our previous students, in that case my recommendation would be that join our there is a different course that we have also added with this one, which is the self-paced theory session, where you get all the recent theory sessions as a recorded version. And I will be adding some new cages there as well. So it's the cages that we have discussed already, and also some new cages we will be adding in that self-paced theory session. And with the self-paced theory session, you can finish your theory within a couple of months. And as a beginner, that is a really a good way to start your preparation. So finish your theory, get an understanding about the approach, different clusters, understand about how AMC clinical works, and then you start these recall classes. Because recall Recall or role play is something when you do when you know things, when you are little bit mature in your preparation, right? So I'm going to discuss with you about these two courses today anyway, so that you can make a good decision that how you want to start your preparation. But whatever your journey is, if you are beginner, middle of your preparation, or you just started your preparation, or your exam is near, you're very much welcome to stay here tonight. Okay. And also remember, this is a fully interactive session, so you get to ask questions anytime. You can also write your questions in the chat box. If you want to open your audio and want to ask questions, or even you want to just be interactive, please feel free to do so. Okay. Can you unmute yourself or the Zoom is just restricting you to unmute? Can anyone tell me?
Yeah, is it okay to unmute?
Good. All right. Brilliant. Now, please make sure that you keep your mic muted for the class, because otherwise we can get background noise. So if you want to ask any questions, one that you can raise your hand, then I can unmute you, or you can write it in the chat box. And sometimes I will ask questions to anyone randomly. Please try to unmute yourself and be interactive, because that gives the class a way of knowing each other, and also you get to become more and more confident as you start opening up, as you start talking in front of people. Okay. So that's the part of this course, because we want you to become confident, we want you to get out of your shell, because many of you feel shy, or many of you feel like I don't want to talk in front of anyone. Maybe I'm if I'm if I'm going to give some wrong answer, then what everyone will think about me. So start forgetting about what other people is going to think about you. Start building that confidence that yes, I might be wrong, but I still want to be interactive. I want to talk about it. I want to ask questions. And that's the way to go from your immature preparation to become a mature or pro preparation. Okay. So let's start our tonight's session. Let's see how we go. Before bef- before I start, I wanted to tell you that I think Arshan has taken a class back in June, where this was the YouTube version of that class. It's a recorded session where we discussed about AMC clinical preparation. It was about introduction. It is a very, very good class where we get to discuss about how AMC clinical works, what's your preparation should be, what are the clusters, and how a examiner mark questions and cages in the exam. So all of those things has been discussed in this session. If you haven't done this class by any chance, please make sure you do so. What I'm gonna do is I will just give this to the chat box so that you can also have a look. Okay. So this was the trial session. I believe like our idea was after this trial class, we were supposed to start the AMC clinical full course, but unfortunately we could not start it this time because of some unexpected issues. Now, I'm not going to discuss in and out about AMC clinical preparation, because I believe that most of you know about it. And if you don't know about it, then please refer to this video. Okay. Now, this year, we are completely focused on role plays. We are focusing on recalls. We are focusing on making sure that our students can pass the exam in the smartest way possible. Now, it's also important to understand that it is not smart to prepare for AMC clinical in a way that you will just memorize hundreds of cages. That's not the way to go. So if you think that you will just do some recalls and role plays and you will pass the exam, that's a very, very bad idea. I only recommend that if you have a proper knowledge about AMC clinical approach, if you have a proper knowledge about the clusters like shortness of breath cluster, chest pain cluster, palpitation cluster. So if you know those cluster, if you know the basics of AMC clinical, then this rapid recall course is helpful for you. If you are a beginner, I might have already told that this is not the course for you. Okay. You might be able to learn about the cages, but it's not going to be the best. So this is mainly for candidates who already prepared or preparing or in the middle of their preparation. For them, this is a very, very good course because we are going to cover all the 2026 recalls. We will try to do role play as many as we can. You have got a lot of classes. So there will be 9 to 10 classes every month, and this course is going to be 4 months duration, right? So there's a huge amount of classes that you will get. And if you, and my recommendation is that every one of you who is going to be part of this course, you should come as a live session. There is no point of doing a role play course as a recorded session. So please do not do that. If you are sure, if you think that yes, I want to pass this exam, then you have to come in the live session, because doing a role play course and doing it recorded, it's not how it's going to work. So part of the part of the criteria to join this course is that you have to be in the class, you have to be well interactive with us, you have to do role play with us whenever we want you to come online. So I know it might not be the ideal thing for a lot of you, but if you are going to pass the exam and if you're doing such a course, you have to do it. There is no other way. You need to make your time. Okay. So the we don't say that yes, it is must that if you are unwell, if you have a family emergency, you have to come to the class. That is exceptional. But as a general rule, if you're doing the role play course, you have to come online, you have to do our live sessions. And one of the criteria is that you have to open your video and you have to do proper role play with us so that we can give you the feedback, so that we can improve your approach, because without that it's not actually possible. Okay. Now, you might be thinking that what if I don't know about the approach? What if I'm not still fully aware of the clusters? In that situation, you join our self-paced theory session plus this rapid recall course. Okay. So we made two courses. This is a bit cheaper because you are just getting the recalls and role plays. This is slightly, the cost is a bit higher because you get all our theory sessions together with this role play course. But if now let's say that you have already done our first aid AMC clinical course, you are our ex-student. For that, I would say that this is your best option to start. You have never done a course, you just passed your MCQ, you want to start your clinical preparation, this should be your way to go. All right. Now, before I go into today's session, I want to just show you what this course is going to look like so that you have a bit of an idea. Is that all right with you? Everyone happy with that? Okay. So if you go to firstaidamc.com.au and if you go down in our courses, you'll find out that this is the rapid recall course and this is that self-paced theory course. So if you go to check info, you can see all the necessary information that you want to know. So course, basically, this is our first day of the course. This is a free session for everyone, but this is a part of the course as well. The course will run for 4 months, so from 29th of July to 30th November, and we'll try to cover almost every recalls, every important questions that is important for your exam in this duration. So classes will be 2 to 3 class per week. You will get 36, sometimes like we might even cross that, like it could be 40 classes over 4 months. So in between 35 to 40, you get the recordings and the notes. So we don't say that, like, if you don't do the live session, you will not be able to even know the cages. You will. Somehow anyone can miss the sessions. We do understand that. If you miss the session, then the classes will be recorded. But those recorded sessions, including the materials, will be available in your portal for a total 6 months, including the 4 months that you're doing the course. All our tutors, so I will be part of your preparation, but there will be lots of other mentors, and every one of them are practicing doctors in Australia. So many of them are general practitioner, many of them are doctors working in the hospital system. The course content for this role play batch is complete 2026 recalls, and we'll do structured role plays. It's not just like doing role plays and be done with it. It is going to be a structured role plays, and also we will give you detailed feedback so that you can improve. Okay, now remember, there will be more negative feedback than positive feedback, because if I just give you a lot of praise and I don't criticize you, you don't learn about this. You are here to learn, so there will be a lot of negative feedback than positive. Yes, I'm going to, if you are doing great, I will give you positive feedback. I will encourage you, I will motivate you. But if you are not up to the mark, you will get negative feedback. Now, please do not take that personally, because again, if you are if you know everything, there is no need to do a course. So you are here because there are some lacking that you might be feeling, right? And we want to improve that. So please have a good shell around you if you get any kind of negative criticism. Now, this is the trial session we're doing today. And after that, we're going to start the class from next week. So I believe the next session will be on 5th of August. So if you want to join the course, you still have got a few days. And in here, you will find out how to contact with us and everything. So if you are an existing student, like you have done our AMC clinical course before, then it is quite affordable for any of you, given the amount of content that we are providing you. And if you're a new student, then this is the cost you can see here. If you want to enroll, then the way to enroll is you just click on this register now button, and then they will ask you some questions and everything, and it will take you to the payment page. If you have any queries, you can contact this email. We have several other numbers. Like if you think that email response is a bit slow, you can even give us a phone call. If you're in Australia, this is the number our admin uses. If you're overseas, you can contact in the WhatsApp as well. Okay. This is the support hours. So please be aware that if you are contacting our WhatsApp or the phone number, this is the hours that our admin works. All right. So that's basically it. If you want to know about the self-paced theory session plus this recall course, please go through that. It's more or less the same, but the important difference is that in the self-paced theory session, you get all these role play classes that we are taking, plus you get the full theory classes. And theory classes are the basics. Theory classes are the main platform you build your preparation. Without these theory sessions, if you have never done any kind of theory or cluster based session, AMC clinical exam is going to be very difficult to pass. So my recommendation again and again is that if you are not completely sure about the approach, if you are not well oriented with the cluster based approach, then you should do our the theory plus the recall sessions. So please go through that. I'll just give you a glimpse of what it is. So you go for that, you get the full recall sessions as we're doing in here, plus you get recorded theory sessions, everything. And we do update the theory classes. It's not just we run the same theory sessions years and years. If you have heard from our previous student, you will know that every year, every every batch, we update our theory sessions, update according to the new cages. Okay, so you will get the same thing. We You might be worried that how you're going to cover the physical examination. In physical examinations, again, the recorded sessions are more than enough to give you a proper idea how physical examinations are working. Now, if you still feel that no, that is not enough, recommendation will be to join our face-to-face physical examination workshop, because this physical examination workshop is one of the best workshop that you can attend, because now it's not because I take it, but definitely it helps students to understand how the physical examination should be done on a person, because you might know the basics, you might know the theory of physical exam, but you need to do it on a person. In exam you need to perform, and definitely I can't show you on a video how this works. I can show in an extent, but there is no best way to just to overlook, to just to see it in person how this actually works. So if you can, if you're not in overseas, if you're here, join our physical examination workshop. The next one is in Sydney. That's one of the best one to attend, and I would say that one of the most important workshop to attend to pass the exam. Now, this has an additional benefit that you get 10 months of recordings, because you get theory session and it takes time to finish the theory, doing role plays, recalls. So you get 10 months of recording. So remember one thing, that there are a lot of courses where you don't get the recordings. Even if you do, you get only for few days, or not even any recordings. But recorded sessions are important, because AMC clinical preparation is vast. And if you do one particular subject, like let's say you have done medicine in the first few months of your preparation, and then 6 months later you did obstetrics gynae. By the time you're doing the obs and gynae, you forgot everything about medicine. And without recorded sessions, you can't even go back and find out, because you might just need a bit of just a little bit of recording to understand or to get back to what you have learned. But without those recorded sessions, it's difficult. So my recommendation is that whenever you are doing any course, make sure that you are well aware of this kind of benefits, because at the end of the day, the recorded sessions really helps our students. Okay. With a self-paced theory session, you also can get 130 CPD point depending on what subscription you choose. And this is the course fee. There are several versions of course fee, so please go through that in your own time. Okay. So that's basically about the course. Do you guys have any questions about the course? No. And if you have done PESCI is not inclusive of all student. It's only for AMC clinical student. There is no face-to-face physical examination workshop in Queensland this year. This year we will only have Sydney workshop. And Dr. Ved Prakash, the clinical course, we just started today. Okay. Yeah, Shams, if you want to unmute yourself.
Hi, Dr. Rakib.
Yeah.
Doctor, I met you in the course for the physical examination 3 months ago. So
Okay.
it was very good course. And I joined the AMC one, the clinical one, in January. But what you said that the course, the one in this year is different than the one before, and the structure will be changed for the next year. So I don't understand what do you mean with that.
Okay. So normally what we do, that you get the theory session as a live session as well, like how we are doing our today's session. But
Okay.
this year, because of lack of our mentor, Dr. Arshan, so we are providing the recorded version of the theory session. So that's only for this year. Okay. But from next year, we will start the live theory session just like before.
Okay. And I've noticed that the one with the theory, it is not having all the recalls. there are many recalls now. It's not there like in with the obscene cases. So I'm not sure if it is in the role play or it is
It's
like
the role play sessions because
in the role play
the theory
stations.
sessions are mainly focused on your structure, building a
Yes.
basic, and then the
Mhm.
role play sessions mainly cover all those new cages.
Okay. And the last question for me, what is the difference between the self-paced, that one, plus rapid role play, and the one that already I joined?
The only difference is that the one that's going to start in January next year, that will be a live session. That
No,
means
no.
that
Okay, that means the one with the self-paced, there is no life.
there is live session of that role play and recalls. So the role play and recalls will be live class, but only the theory part will be recorded.
Okay.
Okay.
But it is the same with this January one for this year.
So, what do you mean?
Like this one, still we have the sessions and we have the theory. So just I want, in case I want to update, because maybe the course will going to finish in the next 2 months. So I need to know if I update this one or I go with the self-paced one.
It's totally up to you. If you feel that, like, if you already started your preparation, sums, then my recommendation is that you go for that self-paced theory, finish the theory as soon as possible, and do our live recall sessions. So this is going
Okay.
to be faster instead of waiting till January.
Okay. Thank you.
Thank you.
Hello, sir. Hello, sir. Can I talk?
Yes, Vet.
Yes, sir. I'm planning to set AMC clinic next year. So, I'm confused. So, can you suggest me which theory section should I join? Because I AMC MCQ I done from your classes, and in last November I passed. And now I'm planning to sit AMC clinical next year. So, which section you
This one.
recommend?
Because if you are a beginner, then
Yeah,
this self-paced will be the best way to start your preparation.
self-paced theory section recorded up to date. This one.
Yeah.
Okay, sir. When will it start?
This one is, so what happens is that this two is a blended course. So this same recall and role play course that we are doing, you
Yeah,
also get this one over here. The
yeah.
only thing that is that you will get the recorded theory session in this course. So you finish the recorded theory sessions by yourself, and then you
Mm.
also get the live role play classes.
Okay, sir. So this section when it start this month or next month?
We so this is the first day of this course. So both of these
Okay,
course, this is the first day, and our next class, which is the like the for students, is gonna start from 5th of August.
5th of August. Okay, sir. So after getting enrolled, I am will able to
Yeah,
done that. Okay, sir. Thank you.
yeah.
Because I have gap in this 6 months with your classes, so I'm very new. Like I'm being very new to the again. Thank you, sir.
Thank you, Vet.
Thank you.
All right. I believe that we can now stop the questions, and then again at the end of the class, we can go back to the questions. Let's do some role play. So who wants to do the role play?
I'd like to do the role play if it's from pediatrics or psychiatry because I'm comfortable in.
Okay, pediatrics or psychiatry. Have you done any other?
I had that, but currently, like I'm feeling blank and I don't feel that I can do role play in other questions or other subjects.
Okay, so I've got a psychiatric case as a case 4. So I will ask you to do this role play, the case 4. Okay. So anyone else who wants to do a role play, who is well aware of AMC clinical? Well, if you're in the role play session, you should be able to come for a role play, right?
I can give it a try.
Joanna, very good. Okay. Joanna, I'm just going to give you the time. Give me 1 minute. So you'll get 2 minutes for your reading and 7 minute 30 second for the case. Okay.
Okay.
And Joanna, are you happy to share your videos?
Is it okay if I
Yeah, it's okay.
don't on my video right now?
That's fine. Okay. Let's do the class. Okay. All right. So this is your case. Joanna, your 2 minute time just started. All right. So this is your patient, Jenny. You can start.
Hi, Jenny. I'm Dr. Chwana. I'm one of the general practitioners at this clinic. I see that you've come because you've had some gradual worsening right hip pain over the past 5 years. And we've done some assessments, so you're just here for us to go through that with you again. Is that right, Jenny?
Yeah, it's fine, doctor.
Okay. Before we start, can I just take a bit of history again from you, Jenny?
Sure.
Okay. I understand that this pain has been going on for 5 years. So can you tell me how that all started? How the pain started?
It just started very gradually, doctor. Initially I thought like it's just a small niggle, but gradually it's just getting worse. And nowadays I can't even walk properly because I'm in constant pain. And I have got stairs at my home, so my husband needs to help me to climb the stairs. So it's just getting worse over the last few years.
Okay, I'm sorry to hear that, Jenny. All right, so if I can just ask you, did you have any fall before this all started? Was
No,
there anything that precipitated it?
no, it
Okay,
just started. I think I'm old, that's why.
okay. All right, was there any other symptoms with the pain? Were you having any weight loss or any loss of appetite?
No,
No. Any lumps or bumps around anywhere?
no.
Lumps or but okay. Any weakness or numbness?
Sometimes I feel a bit weak on my right hip. It's mainly for the pain, but otherwise it's okay.
Okay. Um, so you're also having difficulty climbing the stairs, and that's mainly because of your right hip pain, or
Yeah,
is there anything else that you think? Okay. Yep. No shortness of breath on exertion, any chest pains?
no,
No. Okay. Okay. How's your bowel motions? How is your waterworks? Are they all okay?
Yeah, it's okay.
Okay. Any headaches, any dizziness?
No.
Okay. All right. So from your medical history, can you tell me a bit more about your medical history apart from your osteoarthritis?
I'm generally okay. I don't have any other medical condition.
So no high blood pressure, no diabetes.
No.
So any cancer screening? Have you done any cancer screening? Is it up to date?
Yeah, I'm up to date with everything.
Okay. So you're not on any regular medications?
I take paracetamol sometimes for the pain, but apart from that, nothing else.
Okay. Okay. Can you tell me a bit about your diet?
What do you want to know?
Like, what exactly do you what does your diet consist of? Any dairy products?
Yeah, like me and my husband, we normally try to grow all the vegetables at our garden, so we eat healthy.
Okay, so you have a healthy diet. Do you exercise? I know you're 72 and you have some osteoarthritis. Do you sometimes exercise?
Yeah, I've got an
Any
acres property, so me and my husband usually go out for a walk. So we do like sometimes at least like 1 kilo every day.
Okay. Do you take any regular medications? I'm sorry, I've already asked that. Do you drink alcohol? Do you smoke?
Alcohol just very occasionally, but no smoking.
Okay.
Go to your next task, doctor.
Okay. From your preoperative assessment, I can see that you've got a thoracic vertebral compression fracture of the T5. And I think this
55.
could be just of the T5. Yeah, T5 fracture. Oh,
What's
sorry.
that?
So this is your thoracic vertebra. So I will show you um, your X-ray. You have at your back, which are your spine. You have your right here up in your neck, which is your cervical, and up coming down your chest, you have your uh, thoracic vertebra or your thoracic bone. So T5 is just the fifth thoracic bone, which shows that there's a compression fracture and there's a loss of the height between the bones of your thoracic backbone. So there's also loss of the height, which could be which is noted on your X-ray, and I think this could be because of osteoarthritis, because you have showed you have a history of advanced osteoarthritis, and I think that's also what's leading to the compression of your thoracic vertebral
Really, I've got a
spine.
fracture at my back. I didn't know that. Does it say when I got the fracture?
Um, So it actually this is just something that we found because we've done your preoperative assessment. The thing is, you
Okay.
never had any signs, you didn't know about it. So
Oh,
this is just
yeah.
something that it showed up in your X-ray because we were doing an assessment to see if you're fit to have your X-ray for to fit for your surgery, hip replacement surgery.
Yeah,
So
okay.
this was something that was just noted. Yes.
Yeah, no, I used to, like I normally get a bit of a pain at the back, but I always thought that it's because I'm getting older. Yeah, it's good to know.
Yeah, as we age, as you've aged as well, so because of all these changes and as yeah because of your advancing age, the bone is started to rust in a way, and so that's what's caused the osteoarthritis, and also can lead to the I think the fracture that we can see here today.
Time up. Thank you, Dr. John.
I'm sorry. Yes. Yes.
Okay, no, that's fine. You've done well. So, but the thing is, now this is a very new case. So, what happens with this kind of case that history, it's not like you need to take a very long history because you can see that there are a lot of other tasks, diagnosis, causes, you have to do investigation, management. So, there is a lot to do in this case. And they have given you everything already, right? So, patient has got osteoarthritis. You need to find out why this patient has got compression fracture. So ask a little bit of osteoporosis related history. Okay. So that's mainly will cover the history. So history you will say 3 minutes, that's max, and then focus on other things a lot more. So let me discuss this and then we can go from there. Okay. But the good thing about you, Joanna, is your approach is very good. You said, so like when I said that it's getting worse, I can't even climb the stairs, you said, I'm sorry to hear that. And that is really important, that mentioning those kind of things means that you are empathic to the patient. If the we see a lot of candidate, like let's say a patient says that I'm having a lot of pain, I can't move without someone else help, and you just start continue asking questions after that. You did not even say something that I'm so sorry to hear that, I'm sure that there will be some support for you. So something, you have to say something when a patient raises concern or when a patient says that I am dealing with some kind of pain, dealing with some kind of mental health issues, anything that is sad, anything that is causing a lot of trouble to the patient's life. You say sorry, you say that I hope that it gets better, I wish everything get well soon. So something from your heart, that makes a lot of difference when an examiner is marking you, because it means that you are not here to pass the exam only, you are already a good doctor, because only a good doctor do that, because you are doing it regularly when you are seeing the patient. That's why it automatically comes into you, right? So you have to make sure that it's for everyone, you have to make sure that you do this every day. And it's not just for passing the exam, you are also practicing, I guess many of you. So you make sure that you show that empathy to the patient, that whenever they're saying something sad, you just don't keep on asking questions. Okay. So first of all, this case we have got advanced osteoarthritis, we have got compression fracture, which is mostly osteoporosis. But the differential diagnosis, you should first think of osteoporotic compression fracture, but not just osteoarthritis causing the compression fracture, because most of the elderly population, when we get compression fracture, we think of osteoporosis. We should not forget about malignancy, because this fracture can be a part of bony malignancy. It could be a metastasis in the bone, could be a prostate cancer, lung cancer, which has got metastasized, right? And multiple myeloma, which is like a bone cancer, and it could be even a traumatic fracture as well. So it's a good idea to ask about that. Did you get any fall that you remember? Did you get any injury to your back? Because it could be just a simple fall that the patient had 20 years ago while he was at work. And that's the fracture that you are getting here. So these are our main differential diagnosis. So how we're going to take history for this case? Give me 1 second. So first of all, now approach is really important. How we approach each case, how we approach a patient, it makes a huge difference in the marking. So how you introduce in each case, try to have a simple thing that's in your mind, that this is how I'm going to start. So whenever we see a case, we check what's the age of the patient, sex of the patient, where we are. Are we in the emergency or are we in the general practice? What's the main presentation? Worsening right hip pain. So this is what we see immediately when you are reading a case. You check these things, okay, within second, and then you read it quickly. You already know it's an arthritis patient, and then this is a patient who is getting a preoperative assessment, and they also added another second diagnosis. So in your head, when you are reading that case in 2 minutes, you just think that this is a 72-year-old female in the GP setting coming for right hip pain. I already know it's the osteoarthritis patient, and incidentally, I have found this patient most likely has a compression fracture. So, what can cause compression fracture in a patient who is 72? Can it be a trauma? Can it be osteoporosis? Can it be malignancy, metastasis? So this is where I'm going to ask history. I'm going to ask history about osteoporotic risk factor because there will be some risk factor in this patient. It's not always just old age. It can be something else. So I'm going to ask about those risk factors. Okay, so that 2 minutes that you get, it's really important that you make a plan in your head that this is how I'm going to start. And people who does that, they don't think, because Joanna, when you are asking questions, you had to think that what you're going to ask next, right? And that way you lost a lot of time. But if you think in your head in that 2 minutes that this is this case, the history should be focused on this, then it makes a huge difference on your history taking. And if you do a right history and if you can make it quick, if you can finish the history in the right amount of time, you will pass that case. Okay, so utilize that 2 minutes outside so that you know what you're going to do when you are into that room. So first of all, we will introduce with the patient, we will reassure the patient. Because the patient has pain, we will offer some painkiller. And then we start asking about the hip pain. So hi Jenny, this is Dr. Rakib. I'm one of the GP in this practice. Very nice to meet you. And allow the patient to say something back to you. So patient will say, nice to meet you, doctor. So a lot of you, what you do that you say this line and immediately after that, you start talking again. You don't allow the patient to say hello to you. Okay, just the first thing that you do becomes a mistake. So please give a little bit of pause and see if the patient is saying hello back to you. It's important, right? And then you will say, I can see from the note that you have been having this right hip pain and you are waiting for the hip replacement surgery. Is that right? Yes, doctor. Well, I'm so sorry to hear that you have been suffering for the last 5 years. It must be very distressing for you. But good thing is that now you're in the hip replacement surgery list. So hopefully everything will be sorted out very soon. Jenny, are you in any kind of pain right now? Jenny will say, no, doctor, I'm fine. Well, so Jenny, are you happy for me to tell, or you can say that, Jenny, is it all right for you to tell me a little bit more about your hip? So always start with some open-ended question. So ask the patient, can you tell me a bit more about your hip pain? Because it's a history, so you will need to ask a little bit about the hip pain. So how bad is the pain in a scale of 1 to 10? Does it affect your sleep? Any associated morning stiffness? Because many osteoarthritic patients can have morning stiffness. Any restriction of your hip movement? What have you done so far? Have you done any physiotherapy, any medication, any injection in your hip? And the most important thing is that, is it is it affecting your sleep? That's really important. And how it is affecting your life. In any kind of chronic illness, we always ask this question because we get to know about the severity based on how it affects someone's life. Remember, a person can have advanced severe osteoarthritis. Still, they might not require a hip replacement surgery if they can manage. So the guideline that we follow in Australia, it's not about the X-ray finding showing that patient has got advanced osteoarthritis and we will just put the patient on a surgery list. It's never like that. The only time we will consider a hip replacement is if a patient is unable to do their daily activities. They're in constant pain. They're getting up multiple times at night. That is the time we go for operation. Okay, so it's important to know that how bad is the pain, how it is affecting your sleep, how it is affecting your daily life. So these are the questions that we should not miss. After that, now remember, I haven't asked about all the Socrates question about the hip pain. Is it important? I already know that this patient has got hip pain. I already know it's an osteoarthritis patient. Do I really need to know that does it go to anywhere? Those questions are important, But because I've got a lot of things to do in this case, I'm not bothered about it. So I'm asking only the relevant, more focused history in this kind of case. Okay. Now, remember one thing. There is a reason why they put this compression fracture here. They want you to ask questions about it. It's not about asking only osteoarthritis question. It's more about asking about this compression fracture that you have got. Okay, because patient is already aware of osteoarthritis. She's going to have a surgery. So she is not interested to know about it anymore. She will be more interested, and you should be more interested to know about this. You should explore more about osteoporosis in this case. So you will say that as part of your pre-operative assessment, when we did a X-ray or a scan of your back, we have found that you have a fracture in your back. Are you aware of it? Okay, patient will say, I had a trauma 1 year ago with twisting of the upper back and it caused a lot of pain. But right now I'm managing the pain. So you will get a trauma. Now, tell any of you, just because there is a history of trauma, can you rule out osteoporosis immediately? Anyone?
No.
Why not? What's the reason? Why we can't? Yeah, Dr. Nizam?
Mm, no, you can't.
Yeah, Jasvin, go for it.
You can't.
Considering
You can't rule out the osteoporosis with the trauma, just trauma history, because even trivial trauma can lead to osteoporosis. So you have, I mean, can lead to fracture. So you need to understand how was the trauma, like how bad was it?
Yes. So you want to find out that whether it was a minimal trauma or a minor trauma, because if patient just had a fall, let's say just had a fall backwards on the floor, and it was a timber floor, not a huge impact, that should not break someone's backbone, right? So we need to know whether there was like a huge fall from a meter. That's a huge fall, right? If the fall was a heavy impact fall and that ended up causing a fracture, that's a traumatic fracture. But patient had a minor trauma and that ended up causing a fracture, that's a minimal trauma fracture. And one of the thing about minimal trauma fracture is that their bones are hollow and brittle, and that's why they have got the fracture. A normal person who has good bone density, they would not get a fracture in that kind of situation. Okay, so it's important to know that what kind of trauma was it. So can you tell me a little bit more about that injury? So you will ask about the detail and you will find out that it was a minimal trauma. Okay, then you will ask that, well, are you having any back pain? Can you tell me a bit more about that pain? So ask a little bit of pain questions there, and how bad is the pain, those kind of Socrates related question. Ask about any associated stiffness, any restricted movement. So find out how bad is the back pain. Is the pain affecting your sleep? Do you need to take medications for this pain? Okay. Have you noticed that you have lost height or you are having a stooped posture? Because patients who get compression fracture, they get this wedging, right? So they get wedged fracture. So if this is their normal vertebra, the compression fracture becomes a wedge shaped fracture. So they get a loss of height. And sometimes the loss of height can be really bad enough that you'll find out they are stooping forward like that, or they're having a loss of height and they have a curved spine, right? So ask them that did they notice that they have got a loss of height or stoop posture? Any difficulty walking or moving due to back pain? Sometimes the pain can be really bad that they can't even do their normal daily activities. So we need to know this, that how bad is this fracture, how bad it is affecting their life. So quick history will be find out, did you know about this fracture before? Yes. Well, did you get a trauma? What kind of trauma? Tell me more. And because of that trauma, are you experiencing any pain? And what else you are having? Stiffness, restricted movement, it is affecting your daily life. Are you waking up at night due to pain? So ask these kind of questions. It's a regular questions we ask every day. Okay, so it should be in your head all the time that Someone having pain in the back, I'm going to ask these questions anyway. Any patients who has got back issues, like even fracture, we need to know whether the fracture fragment is putting any pressure on the spinal cord or the nerve root. So that's why we are asking about these questions. So like any numbness, any weakness, any tingling in your legs. So that will say that this patient has got some neurological symptoms because of the fracture fragment. Any bowel bladder issues to rule out cauda equina syndrome. So these are always important for any back pain patient to find out any neurological deficit. After that, you ask about red flag to exclude any malignancy, because we know that one of the differential for this patient could be malignancy. So loss of weight, loss of appetite, any unexplained fever, night sweats. Then you go for osteoporosis risk factor. So how's your general health? Do you lead a healthy lifestyle? Are you physically active? Because patients who are sedentary, who doesn't go for a walk or exercise, they tend to get more osteoporosis than a person who is very active. So do you spend much time outdoors or do you stay in the house most of the time? Ask about the diet, because someone who is lacking calcium, vitamin D, they can have osteoporosis. One of the very important thing to rule out before we start treating osteoporotic patient is if they have got vitamin D deficiency. So do you consume dairy products regularly? Because we know that milk gives calcium, so that's why it's important to know. Do you take any supplement, especially calcium or vitamin D? This is a female patient, 72. Post menopause always is a risk factor for osteoporosis. So when did you get the menopause? Sometimes if the patient has got a premature menopause, like when she was 35 or 40, she got menopause. So she has got a prolonged menopausal history. And in those patients, the risk of osteoporosis is much higher. So that's why we're asking that when did you get your menopause? Did you take any hormone replacement therapy? And then ask about any other medical condition like thyroid disease, diabetes, any other hormone related condition, any history of cancer, kidney disease. Do you take any regular medication, especially any long term steroid? Because long term steroid is a risk factor. You know that steroid can make the bone brittle and thin. And lastly, you finish with smoking history, alcohol history. Have you ever been diagnosed with osteoporosis or osteopenia before? Important to know. Patient might be already a diagnosed case. Any history of fracture after minor trauma? Any family history of osteoporosis or brittle bones? So if a patient doesn't understand, so anytime you use a medical jargon, patient can immediately ask, what's that? So you need to say that any history of osteoporosis or brittle bones. In that case, you explained it anyway, so they will not bother. And have you got enough social support? Which means who do you live with at home? Do you have enough support? Any elderly patient, this is an important question to ask, because we also need to know that whether they are living alone. What's the problem with living alone in an osteoporosis patient? Anyone? Why we are worried about that?
Frequent falls.
Yep, very good. Yes, this patient can get frequent fall, and if they're alone, they might end up getting a fracture and they will not have anyone to even take care of them, right? So important to know that whether they have got anyone, even neighbor, friends, family members nearby. All right, so that's the history. So now, if you find out that you don't have much time in this case to take a detailed history, you just ask quickly about the osteoarthritis question, ask about the trauma question. The patient mentioned that she has got a trauma 1 year ago, and quickly ask about the back pain. Red flag must. Osteoporosis risk factor, you can make it a bit smaller, right? You can say that do you have healthy lifestyle? That covers diet, that covers physical activity, everything. If a patient says that yes, I do healthy lifestyle, you really don't need to ask physical activity, diet additionally, right? Because it should cover that. If you have time, then you explore a little bit more. So you also need to know that if you are running out of time, what you can get rid of from your history. In your mind, when you are preparing for the exam, you know already, you have to know that if I'm gonna run out of time, or I've got a bigger task, these are the things I'm not gonna ask. If it's only a two task history, like if it's a two task case, then yes, I'm going to explore all of this. I'm going to ask more and more detailed question. So you need to know those things, that what you can get rid of during your history if the task is like 3 or 4 tasks. Okay, that's the smart way. So once you have done that, let's go for explanation of this case. So you will say that thank you so much for all the information, Jenny. I understand that you are currently being assessed for surgery of your right hip because you have got the osteoarthritis. The arthritis in your hip appears to significantly affect your daily activities and also your quality of life. And I can see you have done all the possible conservative treatment. It did not give you enough relief. So the specialist has discussed about the hip replacement surgery with you. However, during our assessment, we also found that most likely you have a vertebral compression fracture. Means that one of the bone in your back, which is the thoracic 5 vertebra, you can, like, because you are seeing a patient, you can show that it's just over here on your back. So you have a vertebral compression fracture, appears to be partially collapsed or become compressed. Let me draw a picture for your better understanding. So patient will not understand anything when you say this vertebral compression fracture. You have to draw a picture in front of the patient. So say that, so this is our vertebra in the back. So you have got several vertebra from neck down to your hip. Normally, these backbones should be in equal length and height. But in your case, one of the vertebra, which is in your upper mid back, known as thoracic 5, has got a bit of a compression. It's not in the equal height and width like rest of your vertebra. So if this is your thoracic 5, the vertebra has become a bit of a wedge shape. This is what we call as compression fracture because the height of the vertebra has got compressed. Are you okay with me? Are you understanding me so far? So it's a very good thing to ask the patient when you have done when you have explained the diagnosis, in this case compression fracture. It's good idea to say that, are you with me? Did you understand what I said? Do you want me to repeat? That's a good thing to say. And then patient, if you explain in a simple way, patient will understand. Then you will say that there could be many reasons of having a fracture of the back, but most likely it is due to a condition called osteoporosis. It's a condition where the bone become weak and fragile over time, and it can easily break even after a minor trauma or even a twisting movement. In your case, there are several factors that can contribute to this. You mentioned that you spend most of your time indoors, have limited sun exposure. So in the history, patient might say that I don't go out, I usually stay inside because of the pain, I can't really go out for walk. So they will give you some of this information, which can lead to low vitamin D level. Also, you don't take any supplements. In addition to that, menopause itself causes loss of bone density in women. The twisting injury you had a year ago most likely caused a small fracture because the bone was already weak at that time. We also need to rule out other causes such as cancer of the bone or any cancer from rest of your body spreading to the bone. Could be infection or any other bone disorders. So you're just giving some differential diagnosis here and say with your history, it doesn't look like that you have a cancer or any other bony disorders. So reassure the patient, but still we give some differential diagnosis. Then you will set to confirm the diagnosis and assess the severity. I would like to arrange some investigations, which will include blood test to check your calcium, vitamin D level, kidney and liver function, thyroid function, your blood sugar, some of the electrolyte such as calcium, phosphate, alkaline phosphatase, and parathyroid hormone. So these are the common investigations we do for any patients who might have osteoporosis, right? So we need to check because someone who has got chronic condition, liver condition, like liver cirrhosis, someone who has got kidney problem, they can have osteoporosis. Vitamin D is very important. You have to mention that in here, and rest of it you can just say. To confirm the diagnosis, I would do a special bone density scan, which is called DEXA scan. With the DEXA scan, I would be able to know whether you have got, like, what's the severity of your osteoporosis. For the initial management, I would like to focus on controlling your pain, preventing further fractures. You can take paracetamol 500 milligram, 2 tablet, 4 times a day if you require to help you with the pain. So it's a good idea to explain that how to take the paracetamol. Although talking about the dose is not so much, it's not super important for exam, but it's still paracetamol, sometimes patients don't know about it. So it's a good idea to say that you can take paracetamol 2 tablet 4 times a day if you need it. Please ensure that you increase your calcium intake, so it comes from dairy products. If your blood tests show that you have low vitamin D, I will ask you to start vitamin D supplementation. Try to do a physiotherapy who will show you some safe weight bearing exercise. Nowadays, the physiotherapist, the osteopath, chiropractor, they are very good with this kind of weight bearing exercise, which can really help the osteoporotic patients. So please make sure that you talk about weight bearing exercise with a physiotherapist. And also, if possible, improve your sunlight exposure for vitamin D. Once confirmed, if it is osteoporosis, I will discuss further medications such as bisphosphonate, which will help to strengthen your bone density and reduce further fracture. Fall prevention is very important. So please make sure that you are well aware of your surroundings. If there is any loose carpets, if there is anything that can make you fall easily, please make sure you take care of that. If you need further help, I can always arrange a occupational therapist to come to your home and they can assist for further fall prevention advice. So you know that in Australia, the OTs, which is occupational therapists, they can come to a patient's home and they can assess that what in the patient's home can increase the risk of fall. Like someone who doesn't have a rail on their bath. So it's important for elderly patients who are a bit obese. Once they sit, they need to hold on to something to stand. Or if they're going to fall, they need to hold on to something so that they can prevent a fall. So having a handrail is really important. Some people will like not have a rail on their stairs, which is again a risk. So there are few things that we can do to make sure that patient has got some help to prevent the fracture, and OT can help with that. So you can always talk about that. And lastly, finish with giving some reading materials, talk about red flags, and review the patients after all the blood tests and the scan results is back. Okay. Now you might think that how am I going to finish all this explanation? You don't. You make it shorter. Always remember, when I create a note, I make it really detailed so that in case there is a case comes where you need to counsel the patient about osteoporosis, you can utilize this. Because nowadays there is a lot of counseling cages, right? So they can just give you the same cage and asking about explain the diagnosis, investigation, and management. They will not ask you to take any history. So in those situations, you need to know how to do a detailed counseling. That's why I usually write it in a bit more detailed way. But when you have multiple tasks, in that case, you need to shorten it. So explain it and make it shorter. You don't need to even talk about this osteoarthritis in here. You just say that, well, I understand that you are waiting for the surgery for your hip for osteoarthritis. However, during your preoperative assessment, we found you have got a broken bone in your back, which is called compression fracture, and draw the picture. See that this alone saves a lot of time. So we also need to know in our head how to shorten our explanation if we need to. Okay, so that's why I said do not just memorize a note. Note helps you to understand what to talk about a particular condition, but in your head you need to know how to shorten it. When I remember a particular case, I do not remember all of it. I only remember the most important things in here. So I remember I'm gonna say what is compression fracture. I remember what's the cause in this patient to have compression fracture. So what are the risk factor? So it could be vitamin D low sunlight exposures, low dietary supplementation, low activities. So these are the things I will pick up. And then what are the investigations I'm going to do? And what will be the management? That's the only thing I will remember. Please do not memorize a note, because what happens that in exam you want to say everything, but in exam you never be able to say everything from a note. It's not possible. So when you are reading a note, yes, read it, memorize it if you want, but in your head you close your eyes and think about the 5 to 6 important things that you will never forget about that particular case. That's the way to do. Okay, everyone good with this case? There is no particular question for multiple myeloma, but you are already asking questions about loss of weight, loss of appetite. Okay. And if there was sign of multiple myeloma, the X-ray would find that out. X-ray would show some of the osteolytic lesions. So it's unlikely to become multiple myeloma anyway. No need. Depends that if the patient is in a constant pain, then yes, you can offer the back brace, just vein. If the patient is not in a lot of pain, then there is no need. Okay, let's go to the next task. You know that these are the bisphosphonate that we use for osteoporosis. So alendronate, risidronate, these are the oral tablets. We have got a denosumab, which is commonly known as Prolia in Australia. That's a IV injection, which is intravenous or intramuscular, actually, not intravenous, IM. So we give it intramuscular, which is 6 monthly injection. And then we have zoledronic acid, which is subcutaneous every 12 months. So these are the available options for osteoporosis treatment. If treatment comes, then you can talk about it. These are the risk factors, which we have already talked about, investigations. Okay. So who is going to do the next case? Yeah, Purindu, if you want. I haven't got any GI case, Arisha, for today. Sarah, no, we should not give HRT to a 79-year. But this question was that did they take HRT after their menopause? Okay, because sometimes they can take HRT for several years and that can protect their bone. But we are not going to give HRT to these patients. Okay, HRT is not a treatment of osteoporosis. It's an added benefit. Purindu, if you want to unmute yourself, please.
Okay.
Okay. Do you want to open your videos?
No, sorry, I'm not in a place to open the video.
That's all right. Okay.
Thank you.
That's all good. This is your case, Purinda. Your 2-minute time just started.
Thank you.
All right, so this is your patient, Rhiannon. You can start.
Hi, Rhiannon. My name is Parinder. I'm one of the doctors here in this practice.
Hi.
How are you today?
I'm okay, but I'm just worried about this itching that I have got on my hands and feet. I'm just worried about my baby.
Sorry to hear that, Rana. May I know if this is a planned pregnancy?
Yeah.
Congratulations. And is this your first
Yeah.
pregnancy?
Yes.
All right. How is your how is your follow-ups been? Have you been regular with your GP?
Yes, I was.
All right. So far, I can see from notes you're 32 weeks pregnant. Since now, have you had any complications during your pregnancy?
Not really. It's been really good.
Well done. So, according to notes, I can see you are, and also you mentioned that you're having itching in your hand and feet.
Yeah.
So, how long has this been going on for?
For the last 1 week.
1 week. All right. So, has this been getting worsening?
It is a bit worse at the moment. That's why I'm here.
Okay. At the moment, are you having any itchiness?
Yeah, I'm still itchy constantly.
Okay, I can give you a medication to settle it.
That's all
All
right.
right. If you don't have any allergies. All right. Apart from your hands and feet, any other places that you're having the itchiness?
No. So I feel like, so what happened that initially it was just hands and feet, and now it's just random. I feel like sometimes I feel itchy on my legs, sometimes I feel itchy around my abdomen. So there is no specific area anymore. I can be itchy anywhere.
Oh, sorry to hear that. Have you noticed any rash in your body?
No.
All right. Any vesicles, rash, any discharge from anywhere else?
No, it's just like I've been scratching a lot. So some areas
Okay.
you can see some scratch mark, but nothing more than that.
All right. Have you changed any medications recently?
I'm not on any medication.
Have you applying any gel or lotion or any body wash that changed recently?
Not really.
Have you had any fever, chills, or colds?
No.
All right. Any travel to anywhere else?
No.
All right. And any yellow color that you have noticed in your eyes?
No.
Have you noticed any change in your bowels, like pale stools, like whitish or?
No.
Okay. Has your urine been darkened color?
No.
Any burning or stinging in the urine?
No.
Okay. All right. And have you got any liver issues in the past?
No.
All right. All good. Any past medical history you're having?
No.
All right. Any allergies you're having?
No.
Do you drink alcohol or smoke cigarettes?
I used to, but since I'm pregnant, I have stopped everything.
No illicit drugs, I'm sure. Thank you. Um, Thank you very much, Renee, for the history. From the history, the most likely diagnosis would be that you're having a pregnancy-related cholestasis, the condition would be called, which means that you're having itchiness secondary to accumulation of bile acids that happens in the third trimester, in the last term of your pregnancy, which could be physiological in some mothers, pregnant females. So this will subside after the delivery, but we will keep monitoring you. Since you say you have itchiness in the hands, legs, and also in the mouth, sorry, in the tummy, and it started a few weeks ago, looks like it's the pregnancy-related itchiness that you are most likely having. I can exclude other conditions of itchiness, such as any allergic reactions, any anaphylaxis, any infections, any like conditions of the liver, like um, hepatitis, also other causes of itchiness. But most likely you're having a mild disorder that you shouldn't be worried about. But I will keep monitoring you about this pregnancy-induced cholestasis, and also I will give you some reading materials to educate you. So please continue taking a lot of fluids, and I will follow up with you with the repeat bloods in the coming weeks. And I can reassure you that it's not a life-threatening condition. Thank you.
Is it going to affect my baby?
Most likely it will not affect your baby, but we will keep monitoring your bloods, Renee, and assure you that there is nothing crazy, nothing significant happening in the next few weeks. In order for that, we will monitor your bloods. Do you have any other questions?
No, thank you.
Thank you.
Brilliant. You still have got 2 minutes. Very good, Purinder. You've done really good.
Thank you.
The history was perfect. I will add a few more things. I will discuss that, but like as a whole, you did ask most of the important questions. Tell me one thing, that how do you differentiate the pregnancy-induced cholestasis? What's the name of this, by the way? It's not what we call it. There is a good name of it. Do you know?
Sorry, forgot that he made it as a
Anyone else?
It's intrahepatic cholestasis of pregnancy.
Yeah. So that's the thing. So intrahepatic cholestasis of pregnancy. So that's the name of this. The important way to differentiate this one from others is that this is the only one which doesn't give any rash. So it gives us itchiness without any rash. That's the way to know. The rest of it will give us rash. Now, what else can it be? There is another case which comes in exam frequently, similar kind of case. Very important differential.
Cholecystitis in pregnancy?
Okay, yeah, that's okay. But there is a specific one for pregnancy. What's that?
Psoriasis flare.
PEP. G, yes. G, what's PEP?
Polymorphic eruption of pregnancy.
That's right. Good. Yes. Polymorphic eruption of pregnancy. Is there any other name of it?
PUPPP,
Yeah, what's that?
purple and the plaque and summer of the pregnancy.
Yes, good. Very good. So the polymorphic eruption of pregnancy, there is another name as well. So if we go there. So PUP. So pruritic, urticarial, papules, and plaques of pregnancy. That's one of the cases that comes in exam as well. Okay. So we'll come to the discussion of all of this. And the other one that is important to rule out is atopic eruption of pregnancy. So the three most important one is this one. So the first one is the ICP, the intrahepatic cholestasis of pregnancy. And then you need to rule out PUP and also the atopic eruption of pregnancy. So these are the three most specific cause of itchiness in pregnancy that we have to say. In the differential diagnosis, if you don't mention this name, you'll not get mark in the DD because these are the most three important differential. Okay, so that's what you missed, I think, Purinder, but otherwise perfect.
So, can I ask a question, please?
Yeah, go for it.
So, if you finish your case early, like Purindu finished it 2 minutes earlier than the time,
yeah,
can you be penalized for it at the exam?
No, it's fine. There are cases where you will finish a bit earlier, but there is no problem with that. If you have done all the important things, you should be fine.
Thank you, sir.
Thank you. All right, let us discuss about this case. It's very important. So we can see here, this is a 32 weeks pregnant patient coming with itching of hands and feet. Lab shows deranged LFT, bile acids 39, right? So history, diagnosis, and differential diagnosis, that's our case here. Let's have a look. So this is from RSCGP that if we have got a pregnant patient who has pruritic rash. Now you get the case which comes with the rash as well. So that's why I have added that. So if there is a pruritic rash or let's say itching in pregnancy, we need to know whether there is any primary skin lesion present. primary skin lesion means there is a rash, not like patient was scratching a lot and that's why there is a rash. Because in this case, in intrahepatic cholestasis of pregnancy, you can get bit of a excoriation, erosion from the scratching, but not the primary rash. So if you have got primary rash, you need to rule out non-pregnancy specific causes, which could be psoriasis, could be atopic dermatitis like eczema, could be contact dermatitis, could be any urticaria or hives, drug-related rash, could be scabies, right? So these are always important to rule out in any kind of rash cases. Then there are pregnancy specific ones, which is one ICP, which doesn't give us any rash. And then if it is in the first or second trimester, then we think of atopic eruption of pregnancy. And if it is late onset, like third trimester, then we have two options. So it could be polymorphic eruption of pregnancy, so PEP or PUP, or there is another thing called pemphigoid gestationis. How to differentiate between these two? The pemphigoid, the rash involves the umbilicus, but in polymorphic eruption, it spared the periumbilical area. All right, let's have a look how this looks like in some pictures. So if you see here, this is a itchy rash. You can see maculopapular rash around the abdomen, but it is sparing the periumbilical area. That's why we are calling it PUP. But this is pemphigoid. It is not sparing the umbilicus. It is all around the umbilicus, right? And it has a bit of a blistery kind of rash. That's why it's pemphigoid. And eczema, we know how it looks like, kind of a bit of a erosion or ulcerative lesions. So, diagnosis and management of ICP. So, intrahepatic cholestasis of pregnancy, it is characterized by pruritus without rash. So, patient will have itching all over the body, but there will be no rash. It is mainly related to increased serum bile acid in pregnancy. And sometimes patient can have a mild deranged LFT, especially the ALT and AST can be elevated a little bit. But this will get better after birth. There are some genetic tendency that if there is a family history of intrahepatic cholestasis of pregnancy, then it can run in the families. Okay. We know about the clinical presentation, which is itching is the cardinal symptom, usually occurs in the third trimester, and the pruritus may progressively get worse. So this is important. That's why I say that it's getting worse, right? And then after the birth, it rapidly clears. Because of extreme itching, it can affect the sleep. Some patients can have features of hepatitis, like they can have jaundice, dark urine, pale stool, anorexia. Those things can happen. And if the patient is not a first time pregnant patient was pregnant before, it's very important to ask that how was your previous pregnancy? Did you get this kind of itching during that pregnancy? Did you get a condition called intrahepatic cholestasis? So you will find out that most likely they got that in their past pregnancy as well. Okay. If we come to the SA Health guideline of managing the ICP, because sometimes in exam you can be asked to do the management of ICP, so you should know how to do that. So let's see how we're going to manage intrahepatic cholestasis of pregnancy. So a patient coming to us with features of ICP, to confirm the intrahepatic cholestasis, we will do the non-fasting bile acid. Bile acid, if it is less than 19, it's normal. Mild means between 19 to 39. That's non-fasting and more than 10 fasting. More than 40 is severe and more than 100 very severe. So you can see in normal or in mild cases, you can just do repeat bile acid and LFTs every 2 weeks. So this doesn't need any specific treatment. It's just follow up. Definitely you need to involve the obstetrician in this case to follow up and manage a plan. But the main treatment is only repeating and following up to see that it's not getting any worse. In case of severe or very severe, you have to start treatment. What is the treatment? The treatment is ursodeoxycholic acid, and that's going to help with the bile acid clear up. And you have to also do lots of tests. So bile acid weekly, liver function test, coagulation profile, all of this should be done weekly in that case. And most of the time we say that it's best to get delivery within 38 weeks, because after 38 weeks, the chance of complicated pregnancy or even stillbirth or intrauterine fetal death increases a lot in this kind of patient. When I asked Purindo that is my baby gonna be okay, the answer Purindo you have given was wrong. So it means that always remember, we know that we want to always give reassurance to the patients, definitely to the pregnant patient. We don't want to scare them up, but it's also important to give them the important information, because if you say that yes, your baby is going to be fine, and unfortunately, God forbid, if something happens, they will blame you because you said that my baby is going to be fine. You did not tell me that what else it can be. So I know we don't want to talk about the worst things, but we also need to prepare the patient about the worst thing. And that's how we make sure that we don't get sued in Australia, because you can lose your registration within a click. So the sacrifice, the time and everything that you have given to become a doctor here, it can go within a second. So it's important to become a bit practical and also safe. That means that we also need to give them the right information, that most likely everything is going to be fine, but there are chances that it can increase the risk of premature birth. And there are instances where there are possibility of stillbirth or intrauterine fetal death. But so we always do this sandwich approach. We give something bad information, so we give a bad news, and then we instantly say that, well, please do not get scared. It's not that it's going to happen to your baby, or it's not that it's very common. And the obstetrician, the team who is taking care of you, is going to constantly monitor your bile acid, monitor your baby and you, so that you can have a healthy pregnancy. So you always give the sandwich approach. You have to say the important information. You have to say that yes, it can get complicated, but always mention that it is not common. But and also, like, we will monitor everything, okay, so that they are aware of it. It's just information. Giving right information is more important than giving false hope, okay. So if a pregnant patient comes to us with this kind of itching or itchy rash, our differential diagnosis, definitely ICP will be there. So intrahepatic cholestasis of pregnancy. Then we have PUP. PUP presents with itchy rash starting on the abdomen, but it is spared the umbilicus. Then we have atopic eruption of pregnancy. Atopic eruption looks like eczema kind of rash. It also spare umbilicus, but most importantly, there will be family history or personal history of maybe eczema, hay fever, asthma. So atopy history will be there. Could be viral hepatitis. So viral hepatitis, patient will have all the hepatitis feature: jaundice, nausea, vomiting. They will have fever, abdominal pain, all those symptoms. It is a pregnant patient, so we need to also rule out preeclampsia, fatty liver of pregnancy, or even HELP syndrome. So preeclampsia question should be asked in this case. That's one of the important thing that you have missed, Parinder, right? So there are set questions for every pregnant patient. For a 32 weeks pregnant patient, we need to ask few pregnancy related questions. So yes, we asked about were you regular with your antenatal checkup. Only one question is not enough. We need to ask that, how is your baby's kicking? Can you feel your baby's kicking like normal? Did you do your sugar drink test to check that whether they have been tested for diabetes? Right? We need to ask about, have you got any discharge, any kind of contraction or spasm in your tummy? So those are some of the important third trimester pregnancy questions that we should ask in every pregnant patient. So we'll talk about it during the history. So, but we need to ask about preeclampsia question. So preeclampsia patient will have high blood pressure, proteinuria, which you can't actually ask, but you can ask about headache, tummy pain. You can ask about jaundice questions. Those questions you can ask. Even we can ask about any blurring of vision, any swelling of your legs, right? Pemphigoid gestation is, we know that it gives us this vesicular rash, but it involves the umbilicus. Autoimmune hepatitis, gallstone, drug-induced, very, very important. We need to always rule out drug-induced liver injury because it comes in exam a lot. In Australia, you might think that like they are very educated, but it's still you will find out that a lot of people take natural products and herbal supplement. Like they buy it from online. They are very good with like online version and getting it from naturopath, lots of natural products, herbal supplements, and many of those herbal supplement has hepatotoxic products. So it's very important that if anyone having liver injuries, sign of deranged LFTs, we need to always ask them that are you taking any over-the-counter drug, any new herbal or natural product? Okay, you'll be surprised that how many do that. And then if it was a case of rash, itchy rash, then we need to also ask about all those eczema, contact dermatitis, scabies, psoriasis. Those questions will come into play. Okay. Let's talk about the history. So you introduce yourself, you reassure, and then you ask about the itching. So how Parindu started, it was good. Like, hi, I'm Dr. Parindu. Nice to meet you. I can see you are 32 weeks pregnant. So was it planned pregnancy? Yes. Congratulations. How are you doing? Patient will say that I'm having this itchiness all over my body. You'll say, I'm so sorry to hear that. But now that you're here, I'm going to find out what's causing this and I'll manage it accordingly. So could you please tell me a little bit more about this itching? So we need to know when did it start? We need to know that is it only in your hands and feet or did it spread to the rest of the body? Is it for the first time in your pregnancy? Is it constant or comes and goes? Does it get worse at any time of the day, especially at night? Which rash get worse at night?
Babies.
Yeah, very important. Scabies. Anything else? Can ICP get worse at night?
Yes.
Yes, ICP also can. So scabies is very important to rule out, and also ICP both can get worse at night. Scabies will get worse with hot water. So very important. Like if you think scabies, then ask that does it get worse with hot water? Anything makes it better or worse? And have you taken any medication or any ointment for it? So that's your itching history. Then what is the most important question in a patient who is having itching? Rash, because that gives us a lot of differential diagnosis. So any associated rash, any redness, any other skin lesions. Then we go to the differential. So we go to the hepatitis. Very important in here because why hepatitis is important. The only reason is that we have got deranged LFT, bile acid is high. So we need to rule out hepatitis in this patient. So for hepatitis, the same questions, any yellow discoloration of your eyes or skin, any change in color of your urine or stool, especially dark urine or pale stool, fever, nausea, vomiting, any loss of appetite, loss of weight, and any tummy pain. These are questions of hepatitis. You all know that. Because this patient has got deranged LFT, we need to know whether the patient has any risk factor for hepatitis. What are the risk factor of hepatitis? Anyone who wants to say?
Uh,
Yeah,
it's alcohol or antibiotic use. It's piercings, blood transfusions, food. So like contaminated food, water.
Mhm.
Also, did I mention IV drug use?
No.
Okay, IV drug use. Also, oh yeah, travel.
Yep.
And occupation
Mhm. What is
uh,
N?
and sexual history, and N was
Needleistic injury.
physical injury.
Yeah. Same with the occupation, right? And the sexual history. Very good, Jasmine. Okay, so that's how, like any patients, if we feel that patient has hepatitis or risk of hepatitis, then we ask these questions straight away. So alcohol, you can ask it at the end, but definitely ask about any recent blood transfusion, piercing. For T, you can ask tattooing, because a lot of tattoo, like they go to Indonesia or Bali and then they do that permanent tattoo, and that needle, that they have used it for multiple people. So important to know that. And then food, especially contaminated food or water, which again relates to the travel history, IV drug use, and occupation, needleistic injury. If you're running out of time, not super important. Patient usually tells you that anyway. And sexual history is very important because you want to rule out a lot of things like HIV, Hep B, Hep C, right? Okay, so once you have done that, you go for other differential diagnosis. So we have pemphigoid. So any blistering lesions, especially around your umbilicus or belly button. Atopic eruption. So any family history or personal history of eczema, asthma, hay fever. Any history of gallstone. Autoimmune. Do you or your family have history of liver problems? And then you ask about any new cream, shower gels, cosmetics, any new soap, any like washing powder. So it's very important, and it's very common in Australia that they get contact dermatitis. So you need to always explore more and more that have you changed your shower gel? Have you changed your soap, detergent, any new cosmetics, any new creams? You will end up finding like a lot of time this is the cause of their rash. Okay. Drug induced. Have you started any new medication, any over the counter or herbal supplements that you're taking? And ask them that, do you take any medication? Especially do not forget about antibiotic, because there is a case of antibiotic induced hepatitis. So if they say that no, I am not taking any medication, then you go for direct question. So have you taken any antibiotic recently? Any over the counter drug or any supplements that you have started? Okay. Viral rash. So sometimes it could be just a viral infection giving the rash. So any recent viral infection. Systemic causes. So do you have any other medical condition like thyroid disease, diabetes, any renal disease or kidney disease? Ask about past pregnancy. Have you ever been pregnant before? If the patient was pregnant before, we need to ask in detail. So how many times? When was the last one? What was the mode of delivery? Was there any complications during those pregnancies? So all of these things should be asked. Past history. So ask about if the patient was pregnant before. So did you get cholestasis during that pregnancy? Any other medical condition, any family history of cholestasis during pregnancy? It's also important, as I was mentioning, that when you are asking this pregnancy related history, in here you should ask all the third trimester pregnancy questions. So third trimester pregnancy question, we say A, B, C, D, E, F, S, T. So that's the mnemonic that we use for anyone with third trimester pregnancy. This is what we should ask. So A for, were you regular with your antenatal checkup? Okay, that's the most important. And in the antenatal checkup, we will ask few more questions. So did you get your blood test, your 5th month scan? Was there any abnormality? Did you get your sugar drink test? If you forget that, then you have S here for OGTT or the sugar drink test. We should also ask about like, did you take folic acid during your pregnancy? So a few of the important questions should come here in the antenatal. B, so any bleeding or any discharge, because it's a third trimester patient. We always ask this question: any bleeding or any discharge from your vagina? Any contraction or a spasm on your tummy? to rule out preterm labor. Can you feel your baby's kicking? Very, very important for this case. Okay. And then T for toxemia, which is pre-eclamptic toxemia. So you ask all the pre-eclampsia questions. So any headache, any blurring of vision, any swelling of your legs, any tummy pain. So all of those will come here. Okay. And any history of high blood pressure. And lastly, finish with SADMA. So any smoking history, alcohol history, and all. All right. So that's your history for itching. So you ask about the itching, ask about the rash, and then you go to all the differential diagnosis one by one. All right. So how we are going to explain this? So you'll say from the history, most likely you have got a condition called intrahepatic cholestasis of pregnancy. Normally, our liver produces bile. It's a fluid that helps to digest fat. This bile travels through tiny channels or ducts from the liver into the intestine, right? During pregnancy, especially in the latter half of the pregnancy, the hormones can sometimes slow down the normal flow of the bile. So you need to give that information to the patient. Why the bile acid is accumulating in my body? Why not in other pregnant patients? So you'll say that some patients, could be genetic, could be some unknown reasons, the pregnancy hormone can slow down the normal flow of bile. So instead of going into the intestine, it start building up into your liver, and sometimes it goes to in your blood. This increased amount of bile acid in your blood will give you the itching that you are having. Usually it starts without any rash, and it can get worse at night. Most of the patient notice first on the palms and soles of their feet, but it can go to the rest of the body in few days. So you just give the diagnosis and explain why this is happening, and then give some differential diagnosis. So differential diagnosis is an art. How you say your differential diagnosis gives a lot of information to the examiner how good you are. So when you're giving differential diagnosis, and there are a lot of cases which comes with differential, you should have a proper plan that these are the things I have asked, and how did I rule out the other differential. That's what you're going to say. So you'll say that it could be pruritic, urticarial, papules, and plaques of pregnancy, or you can just say it can be polymorphic eruption of pregnancy, but it has rash associated with it. So in your case, it's unlikely. Could be atopic eruption of pregnancy, but in that case, patient also have a rash, and they have family history or personal history of lots of allergies, eczema, hay fever. It could be another condition which is called pemphigoid gestationalis, but you don't have rash, which these patients usually would have. Could be viral hepatitis, but you don't have any symptoms of hepatitis. Could be preeclampsia, which is a complication of pregnancy, but you don't have high blood pressure, you don't have headache, you don't have any other features of preeclampsia, which is good. Could be gallstone, but you don't have any history like that. Could be sometimes some medication induced, but you are not taking any medications at the moment. Could be some other dermatological or skin causes, such as eczema, contact dermatitis, scabies, but all of them would give you a rash, which you don't have. Okay, so that's what you need to say in the differential diagnosis. Now, this case is only about diagnosis and differential, not about management, but who knows, it can be a management in the exam. So you should always know. If you see that there is a case frequently coming in exam, you should know each and everything about it. Okay, don't just finish with diagnosis and differential, because next exam they can give you management. You should know that. So you will say the good news is that this is not dangerous for your liver in the long term, and almost all women, it will completely resolve after the delivery. The main reason we take this condition seriously is because it can have some effect on the baby, not the mother. Most of the baby do very well, but if the bile acid becomes seriously high, like it's severe, then it has an increased risk of the baby to become distressed. Especially, it can cause preterm delivery and, in rare cases, fetal death. I'm so sorry to say that. Please do not get scared. We are going to monitor both you and your baby carefully throughout the pregnancy. So that's very important. I'll also send you for further investigations such as blood count, check your liver function again to see if it is getting any worse, and check the bile acids and hepatitis serology. Treatment is ursodeoxycholic acid. It helps to improve the bile flow and reduce the itching. For symptomatic relief, you can advise the patient to take some moisturizing creams, wearing loose cotton clothing, and avoid hot shower. And yes, we are gonna involve a obstetrician, and delivery should be by 38 weeks. Okay. After delivery, most of the time within few days, 2 weeks, this should get better. And the specialist will repeat your blood test after delivery to make sure everything is okay. It's important to mention that there is 60 to 90% cases. If a patient gets this condition, they will get this back in future pregnancies. So it's important that you mention it if you ever get pregnant again, that you had this condition. Okay. All right. So that's how we are gonna manage this case. Do you guys have any questions? No, everything good? So I think we are almost at the finish of our class. So normally we can do 5 to 6 cages in 2 hours. Sometimes we go beyond that. So usually sometimes we can even take a class of 2.5 hours to see if we can finish more and more cages. But today I did not want to overwhelm you with lots of cages, lots of discussion, and we had to discuss a lot about the course anyway initially. So that took a lot of time. But this is how the role play sessions are going to look like. Now, again, there are lots of other mentors who are going to take your classes from next week. So for students who has already enrolled, you might have seen the schedule in your Facebook group. Otherwise, like if you guys are also enrolling, then we'll add you into the Facebook course group as well, where you can see all the schedules. But I remember it's should be 5th of August when we are starting the course. Okay. Do you guys have any questions about anything that you want to ask? I hope you enjoyed the session today. Sarah, if you enroll tonight there is no admin because it's overnight. So most probably you will get access to the portal within 2 days. Next class, Shaija, it will be 5th of August. So just in few days. Thank you, Sarah. I hope that because what I want you to learn is not just cages, you also need to know how to become a good doctor in Australia. And our focus is to make sure of that. I want you to think when you say something. It's not about just memorizing things. It's about knowing the cages in a way that covers the important things. Okay. Yes, these are recall class, Ajeja. Saija, yes, I will take other classes as well.
And just a quick question regarding the last case we did. Somebody asked about, do we refer this patient to the high-risk pregnancy clinic?
Yes, we do. Because even though it is not something that we are really worried, but because it can affect the baby, we are going to. So when we say we are going to involve the obstetrician, it becomes a high-risk pregnancy case.
Because in the Australia, there is like kind of when there is a pregnancy related patient, now we have 2 or 3 kind of settings. Either is a midwifery group, so that's a separate thing,
Yeah.
or a GP practice, which is associated with hospital,
Mhm.
or there's another one, maybe hospital-based clinics. So then do we need to be, complicate ourselves so much or just let them know?
No,
Yeah.
this is, you don't need to complicate like that. Yes, there are midwife based, and then there is shared care with the GP, and then the worst cases go to the obstetrician, which is in the hospital setting. But you don't need to do, like, you don't need to complicate this. So just say that you are going to involve your obstetrician and send a referral letter to the obstetrician in the hospital, and they will take care of you. And that becomes a high risk pregnancy case anyway. We don't say high risk pregnancy in Australia, we say complex pregnancy. Okay.
Okay, so then, like at this point, let's say there's a management. So we referring or not? That's
Yeah,
always
we
a
will refer.
confusion.
We'll refer, definitely refer. Refer means that you will just write a referral letter to the hospital, and it's not an immediate thing that the patient will be seen immediately. So within 1 month or within 3 weeks, the obstetrician will take over. Okay.
Okay, thank you.
Jasvin, any tips to finish on time? Role play. There is nothing better than role plays. So if you want to finish on time, you have to do a lot of practice, a lot of role plays. And with role plays, you will know that how much you can finish. Okay. And utilize that 2 minute, because if you are good with utilizing that 2 minute outside, and you already know in your head that this is what I'm going to ask, you will be able to save a lot of time, because people mainly lose time when they think in their head that what should be my next question. I can't remember any question, and you get blank for 30 seconds. That's when is the problem. The acute fatty liver will never come in exam because it's very rare, and it's very severe thing. So those kind of cases usually don't come in exam, which is like very rare, especially the acute fatty liver. But like, like the other differentials which are common and we should never forget it, we will definitely discuss that, how to differentiate between these. That's important to know. Yeah, G, if examiner says that you should move on to the next task, sometimes they do that. If that is the case, you need to move on. It means that examiner will only do that if you are really running out of time. Nowadays, what happens that there are cases where you get the timing, like history for 3 minutes. So after 3 minutes, you get a bell, which means your 3 minute history is done. You should wrap up your history ASAP, and then you move on to the next task. Okay. It is important that you don't take another minute after that bell, because the bell means that you have only 3 minutes allocated for that history. You may take 15 seconds more than that, but you should not take 1 minute after that bell, because that means that you're not actually caring about this timing. All right, and they don't like it. The prompt usually given if in the history it is written, like if in the task it is written, the take history for 3 minutes. Usually when they write this thing on the task, you will always get a prompt. Sometimes if examiner likes your approach, they can give you prompt that move to the next task. It's not common, but they can. Supriya, sorry, we can't go to that like full course information. This class will be uploaded on our YouTube. Okay, so you can definitely go into the YouTube and finish that first half of the class, and we will also add that YouTube link on First Aid AMC Clinical Facebook group. So it will be uploaded by tomorrow morning or tomorrow maybe at night. So you'll be able to go through that. Is that okay? Brilliant. All right, everyone, thanks a lot for your participation. I hope you really I hope you liked the session. If you have any queries, anything, you can always reach out through the email. You can always send message to Arshan on the messenger. Arshan is not there, but there will be an admin who is taking care of that. So someone is always there to help you with any queries. Okay. G, for PE on mannequin, should we explain verbally each and everything as real patient? Yes, you have to explain. So in mannequin cages, there is usually a role player as well. So role player usually sit beside the mannequin. So you explain and you take permission from the real person and you perform the exam on the mannequin. Saja, I don't know because there's not much of a time left. We are not completely sure about Melbourne. I am in Melbourne, so I can take a session if I can manage. So I will see. I'll see after the Sydney workshop. If if we have some time, then maybe we can arrange one for just before the November exam. So second week of October, there is a chance, but I'm not certain at the moment. All right, guys, thanks a lot. Have a good one. We'll see you soon. Bye.